Good afternoon or good morning, everybody, and welcome to today's webcast on the power of patient stories for improving the patient experience. My name is Dale Schaller, and I'm going to be moderating our session today, which is presented by the Agency for Healthcare Research and Quality, or AHRQ's, CAPS User Network. Next slide. Our agenda, we begin today with a brief welcome and an overview from AHRQ describing how the research on patient narratives fits into the overall CAPS program. And then we'll move on to two presentations. The first on the power of patient stories or patient narratives to illuminate the patient experience in ways that closed-ended survey questions often don't fully capture. And secondly, how patient narratives can be used in concert with CAPS survey questions to guide the quality improvement process. And as always, we aim to leave as much time as possible for your questions, which we encourage you to submit at any time during the webcast, and I'll show you how to do that in just a moment. Next slide. Just a few housekeeping details. If you have trouble hearing the audio from your computer speakers, you can change the audio selection shown here so that WebEx calls you back and then you could connect to your phone. If your computer freezes up during the presentations, you can always try to log out and log back in to refresh the page, and then onto the Q&A feature that you can use at any time. Next slide, which is located in the lower right-hand corner of your screen. You just look for the drop-down option that indicates all panelists so that when you type into a question, we will all be able to see it. And we also encourage you to share your name and organization if you're inclined to do so, so we have an idea of where you're coming from. Today's session is being recorded. We get that question a lot. And then a replay of today's session will also be available in the future, next several weeks on the CAPS website. You may also download the slides for today's webcast already by going to the webcast event page, which should be shown as a link in the Q&A part of our screen. And it should have also been sent to you on an email earlier today confirming your registration. So next slide, I'd like to now welcome and introduce our speakers for today, beginning with introductory comments from Karen Ginsberg, who directs the Agency for Healthcare Research and Quality's CAPS program, as well as the surveys on patient safety culture, or SOPS program. Karen will be followed by Rachel Grob, who directs the National Initiatives Program at the Center for Patient Partnerships at the UW-Madison. Rachel is a founding and central member of the CAPS Narratives research team. And Rachel will be followed by Ingrid Nebhart, who is an associate professor of healthcare management at the Wharton School. Ingrid leads the CAPS team of researchers that are associated with the Yale School of Public Health, working on the collection and use of patient narratives for quality improvement. And again, I'm Dale Schaller, and I've been a longtime member of the CAPS Consortium, serving as your moderator. More bio information is available on the event page for today's webcast. And with that, Karen, I'm pleased to turn it over to you for your welcoming remarks.
Thank you, Dale. Welcome, everybody. I'm so happy to be able to present this work to you today on using patient narratives with CAPS surveys for quality improvement. And before we get started, I'd like to provide some context for the work you're going to hear about today and why it fits into the priorities of the Agency for Healthcare Research and Quality, or AHRQ. And when you registered, and thank you for providing information about yourselves when you registered, I noticed that there were many new users to CAPS surveys that had registered for this program, and also that many of you indicated who were familiar with CAPS surveys that the survey that you're most familiar with were surveys that were required by other agencies or organizations for participating in a program. So I wanted to start off by telling you about what AHRQ does and AHRQ's interest in the CAPS program and the narrative research that you're going to hear about today. So can I have the next slide, please? So the Agency for Healthcare Research and Quality is basically a research and development agency. That's what we do, research and development. We're part of U.S. Department of Health and Human Services. We're the lead for federal agency for improving the safety and the quality of America's healthcare system. And the way that we do that is with our core competencies of health systems research, practice improvement, creating tools for providers to use to improve care for their patients, and generating data and analytics that you can use to track the progress of the U.S. healthcare system. And so the CAPS program here at ARC conducts research and development on patient experience. We create tools to measure it, narrative item sets, as well as the standardized CAPS surveys, research on quality improvement and patient experience. And we even have some databases for selected surveys where you can, if you want to, submit data, and we'll give you a feedback report. But it's a voluntary effort on your part. There's no requirement to use our tools. We're not a regulatory agency, so we can't really require that you use any of our tools or products. So can I have the next slide, please? So when we talk about CAPS surveys measuring patient experience of care, we're talking about a standardized survey instrument that basically addresses the questions: what happened to the patient in the care encounter? Did something happen? And how often did it happen? That's what's meant by patient experience of care. These are objective questions that are actionable for quality improvement. The CAPS surveys encompass the range of interactions that patients have with the healthcare system. And I want to point out to you that sometimes patient satisfaction and patient experience are used interchangeably. I want to point out to you that they're not the same concepts at all. And whereas we just talked about how patient experience was objective and actionable, a patient satisfaction survey assesses how patients feel about their care, and those feelings are often based in what their expectations were for that care encounter or care setting. And so those kinds of questions about feelings aren't really actionable for quality improvement. They're subjective. So I want to point out that difference. So CAPS surveys typically measure things like communication with providers, timely appointments, care coordination, access to information. And I also would like to mention to you that you can customize your CAPS survey with supplemental items. On the next slide, we're going to start talking now about the narrative item sets, which are part of the CAPS survey offerings on the supplemental item sets. The narrative items that we're going to talk about today are used with a standardized CAPS survey. They are a structured series of open-ended questions that ask survey respondents to tell a story about their experiences in their own words. They provide additional information to the closed-ended CAPS survey questions and help you interpret the CAPS survey responses that you'd receive. And they provide value-added information that's helpful for everyone, for patients, consumers, providers, and staff. The narrative information, the narrative item sets were developed and tested with an established methodology to ensure scientific rigor, and the way that all CAPS surveys are. And so I just want to make sure that everybody realizes that there's a structured process in their development. And then finally, on the last slide, I just want to point out we have a growing family of narrative item sets. Can I have the last slide, please? We have on our website the clinician and group narrative item set, and the narrative item set for the clinician and group surveys, as well as, and we are in the process of developing item sets for health plan CAPS as well as child HCAPS. So with that, again, welcome, and I'm going to turn this over to Rachel. Rachel, the floor is yours.
Wonderful. Thank you, Karen, and good afternoon, one and all. It's a pleasure to be with you today. My job during the next 15 minutes, next slide, please, is to weave for you a story about the power of stories. And this story has a lot of parts. Ingrid will talk about their power for quality improvement later on this webinar. And the CAPS team has a variety of publications and projects addressing other issues such as public reporting and how to rigorously elicit narratives. Today, I'll be focusing on how stories can powerfully complement CAPS surveys. We need to keep moving these slides. I don't know if there's trouble doing that. I'm hoping to be on the slide that has pictures from the COVID pandemic. The main character in the story is one you've all met, wrestled with, worried about, and contemplated over the past 20 months. COVID-19. COVID's an apt protagonist because it's immediately salient to all of us here and because it illustrates how narratives can function as a herald for survey design, capturing how patients' experiences are changing in real time. Using data from nearly 8,000 CG-CAP surveys fielded within New York Presbyterian's ambulatory care network between July 2020 and December 2021, surveys which included the CAPS supplementary narrative item set that Karen just mentioned, I've done an analysis of 2,100 comments we received on more than 1,000 surveys, which included mention of COVID. I am not seeing these slides advance. I don't know if other people are, but I am going to keep on going here. I've used this analysis to create a tale designed to illustrate my own meta-narrative for this talk, which is about the power of stories to add value to CAP surveys in 3 distinct ways, which we summarized in a Milbank Quarterly article our team published a couple of years ago, and that you would be seeing on the image here. I hope you are, and just I am not. One way is by providing concrete, actionable examples of aspects of care already being measured on CAP surveys, and we call this integral feedback. Another is by highlighting elements of competence that are not being directly measured, so within the existing domains, but aspects of them we don't measure, and we call this proximal. And the last is by highlighting domains of care that are important to patients, but not yet included on the CAP surveys to which a narrative item set is attached. The next slide shows a distribution of the 2,100 comments I mentioned by domain. And in red on the left-hand side, if you could see that, are highlighted the integral or proximal domains, which is about 1/3 in total. And on the right, those that were the distal categories. Okay, now I see these slides advancing. So that's the one that talks about integral, proximal, and distal. And the next slide will show you the distribution I was just mentioning. So you can see that we got a lot of information about COVID that was outside the domains of the CG-CAP surveys, which on the next slide, I'll remind you, as Karen already did, that those 4 domains are communication, access, office staff, and care coordination. So on the next slide, I'm going to show you some themes that were integral to the communication domain. I don't have time to talk about the other 3 domains because we have a lot of data to share. Narratives patients told about getting care during COVID illuminated how their experiences with items on the CAP survey, such as length of appointment time and feeling respected, listened to, and having things explained, were mediated or changed by the pandemic. They spoke, for example, about how providers, quote, explained the COVID-19 vaccine to me and listened to my concerns. They also noted how masks could be a challenge to absorbing what was being explained. As one respondent put it, quote, I have hearing aids and it's frustrating not being able to hear my doctor's words while wearing a mask and a face shield. Sometimes I leave the appointment not being sure of what she said because I have to keep saying, what? It's not anyone's fault but COVID. I long to be able to read lips and hear exactly what the doctor says. Another person described how the protocol of speaking to the doctor by phone from the examining room, presumably to shorten length of time spent in a room together, degraded communication because of a poor connection. There were several times that I misunderstood the question about my health that she asked me, this patient wrote, and answered incorrectly. With hindsight, there must be a better way to allow the doctor to talk to the patient when the patient is waiting in the exam room. Some respondents have been amazed that their doctor is, quote, listening and not hurried. So incredible during this time of great stress on all providers. Others said that their appointments were rushed or too short. In the words of one, my only criticism is that the exam was very short, the shortest I've ever experienced, and I'm 63. I chalk it up to COVID-19. In the proximal domain, next slide, COVID also added new dimensions to our understanding of experiences with communication. Next slide. Patients talked about how reassuring it was to, quote, spend a great deal of time with providers, quote, just talking about the pandemic, about being in quarantine, etc., and how this was, quote, most reassuring. Others wished for more in-person interaction or emphasized pragmatic aspects of communication about COVID testing, infection, and vaccines. Next slide. Access issues were affected by COVID in a number of specific ways. Many people hadn't seen their providers for months, but said they understood this was because, quote, COVID threw a monkey wrench into the picture. Some noted they wished access could be better because, quote, the distance and precautions are simply cumbersome. But again, they get why it wasn't. The only thing that I wish was different, said one, is that the virus was not here. I cannot had my teeth since last year, but now I'm still waiting a year later and no teeth. Others expressed gratitude for telehealth visits or for being squeezed in despite the pandemic. Some offered specific vignettes, such as the woman who accepted her clinic's explanation about why COVID meant her husband couldn't accompany her for prenatal care, but who, quote, still didn't feel extremely comfortable in there without him. Being given the option to include him via FaceTime helped some, making her feel, quote, that people cared. Next slide. The CG-CAP survey asks about respect, courtesy, and helpfulness of office staff. Appreciation for all of this was highlighted in the narratives, but some also focus on office staff being reassuring and compassionate during a frightening time. Others describe seeing, quote, the people that usually work there and how empty and sad the clinic feels now that, quote, nothing is the same as it was. One respondent explained how upsetting it was to have to, quote, yell out my personal information across the waiting room and front desk from more than 6 feet away when office staff were not comfortable observing the actual 6-foot rule. Next slide. People had a lot to say about new dimensions of care coordination during COVID. They were grateful when clinics directed them to timely COVID testing, making it possible for them to gather more safely with family and friends around holidays. Once vaccines became available in late 2020, patients had a lot to say about the way their providers either facilitated or failed to facilitate access. Some described calling and calling, but getting no answers, and eventually finding vaccine options another way. Others said that their clinic made vaccine appointments for them, sent them reminders, explained procedures, coordinated vaccine issues using the electronic health record, or worked hard to get them vaccinated while on site for other reasons. Next slide. News stories also evolved during COVID. One is about patients' empathy with providers, compassion for the difficulties associated with their roles, and understanding that it would be impossible to meet patients' needs per usual. We've been calling this grace for providers. Patients voiced appreciation for responsiveness and good care, quote, especially in these times when, as one patient put it, I realize the medical profession is overburdened, or as voiced by another, when, quote, everyone seems exhausted and burnt out. Other patients note providers are overwhelmed and that problems with care are not the doctor's fault. They understand that delays getting appointments, rushed visits, and lack of in-person contact is because COVID is, quote, keeping providers running. Say they are, quote, comfortable with the current status given the current pressure medical staff is working under, and note that they, quote, give some leeway because COVID is the culprit. Next slide. Another COVID story is about care received related to the virus itself. People described getting, quote, clear and caring guidance about COVID via telehealth visits and getting help discerning if and when to go to the hospital. I developed pneumonia, said one patient, but did not want to go to the emergency room. Dr. X convinced me to do so. In my opinion, she saved my life. Another described how their doctor, quote, took his time to thoroughly advise me as to what I should be most concerned about and when I should consider a visit to the ER should symptoms worsen. He checked in with me every 2 days and immediately responded to my questions via the patient portal. I could not have felt more confident and secure that I was in good hands. Some patients also had ideas for how COVID care could be improved. When I got my positive COVID results on an automated system, one said, I wish that I would have been informed by a personal phone call first. I was frightened. A number of people spoke about their providers helping them with mental health issues, with loss, and with shame. I was feeling depressed and anxious since the pandemic, wrote one, and the doctor made sure I had access to therapy, medication, and whatever else I needed to feel better. Another described worry about, quote, being judged as a professional with no insurance, but overcoming, quote, pandemic embarrassment over lost employment, making an appointment to get care, and then feeling thankful for excellent and non-judgmental treatment. Having lost my husband during this horrific pandemic, said a third, my PCP reached out to me to see how I was doing. It was such a wonderful gesture and so genuine. Next slide. Patients offered specific narratives about safety during COVID. For some, the new arrangements and waiting areas and public spaces worked well. For example, immunocompromised patients appreciated being immediately placed in a private room when they arrive at clinic. Others noted that some specific waiting areas were empty, while others were crowded in a way that, quote, goes against social distancing rules. Patients with disabilities or little stamina struggled with lack of chairs to sit on and with not being able to stay in the waiting room after their appointment while waiting for a ride. Some described difficult workarounds, trying to find a place to sit outside the building until their taxi or Uber arrived, wondering, quote, where is a patient supposed to go? Because of COVID-19, one wrote, half of the waiting seats for patients have been removed. This caused us patients to have to stand in the hallways while waiting for procedures. After standing for half an hour, I rescheduled my appointment for another day. Slide. Finally, powerful narratives emerged during this period regarding institutional policies developed in response to COVID. A number of people noted that processes have, quote, actually improved with new COVID protocols and that staff are now efficient and quick, or that everything now feels, quote, safer and more streamlined. Some gave specific examples, such as having the phlebotomist come to the exam room to draw blood instead of having patients change locations. Others objected to what they saw as violations of rules the institution had itself set. According to the new protocol, wrote one patient, companions of the patients are prohibited except when these have special needs. However, violating their own rules, they did not let my daughter in with me, and they did not care that I don't walk without her help, that I have vertigo and memory problems. The question of better, more transparent rules also arose in the narratives, with suggestions that, quote, strange protocols due to COVID be explained to patients before arriving, or that more than one parent be allowed in with their child. Patients also described when the institution failed to enforce its own rules, particularly with respect to social distancing and masking in waiting areas, and hoped it would continue to get better at this. Next slide. Stories like the ones I've just been sharing with you are powerful. We know that they can affect our heart rates as well as our metaphorical hearts, unconscious responses in our amygdalas, as well as our conscious thoughts. They can also be misused, unbalanced, unrepresentative, and difficult to make meaning of. I know I speak for many in saying how much we appreciate the CAPS program for understanding that stories can be a powerful part of the science of patient experience. Next slide. Because imperfect as stories may be, they, as an element of patient experience measurement, they also are essential. As cognitive scientist Mark Turner put it, narrative imagining story is the fundamental instrument of thought. Rational capacities depend upon it. It is our chief means of looking into the future, of predicting, of planning, and of explaining. Narrative work makes the CAPS enterprise more powerful, next slide, and more able to capture the actionable insights and creative ideas patients can contribute to care quality. Ingrid's going to pick up on this in a moment. As you can see at the top of the slide here, one of our New York Presbyterian respondents had an idea that presaged the CAPS program's own implementation of the telehealth survey. And lower down on the slide, a recent UK-based study repeats and specifies the finding that many patients find it gratifying and engaging to give feedback through stories. As we proceed with analysis of narratives like the ones I've just shared with you, implying an equity lens is something that we'll have in mind. Everything must be made, next slide, as simple as possible, but not simpler. I will leave you with the thought that rigorously elicited and analyzed stories are part of getting the alchemy of patient experience measurement just right. Not too simple, not too complex, as is appropriate for its critical role improving American healthcare. Thank you, and I'm going to turn this over to Ingrid with acknowledgement, of course, of our partners.
Thank you, Rachel. I think Rachel has done such a lovely job of showing us the power of patient stories. I think it's clear that patient stories are rich in insight. Knowing that they're so powerful in that regard, I think the natural question becomes, how can we use their stories to improve the quality of patient care experiences? And so that's where I'll focus my time. My intent is to have us consider the ways in which patient narratives serve as a tool in improvement. Before I say more about that, though, let me acknowledge, so next slide, please, that this work has been funded by a cooperative agreement with the Agency for Healthcare Research and Quality and developed without commercial support, and I have no conflicts of interest relevant to this work. So now let me turn to the topic of using narratives for quality improvement. Next slide, please. So I think it's helpful to recall the definitions of quality and quality improvement as a starting point. The literature on organizations has given us a definition of quality, which is that quality is the ability of a product or service to consistently meet or exceed customer expectations. In healthcare, we've tailored that definition to our context and regard quality as the degree to which healthcare services for individuals and populations increases the likelihood of desired health outcomes, and that they are consistent with current professional knowledge. The nuance in this definition, I think, is actually quite important. Quality exists when we increase the likelihood of desired outcomes. Now, positive patient experiences is a core desired outcome. We all know that there are opportunities to improve on patient experiences in many regards, whether it's coordination of care or equity. And thus, quality improvement is imperative. As I talk about quality improvement today, I'm referring to quality improvement as the use of process-based, data-driven approach to systematically improving the way care is delivered to patients. It involves continuous efforts to achieve stable and predictable process results. That is, to reduce the process variation that we often see and improve the outcomes of these processes, both for patients and for healthcare organizations, systems, and the people who work within them. Next slide, please. So, sorry about that. So when we think about quality improvement, perhaps the most widely used improvement framework in healthcare is the model for improvement. The hallmarks of this approach are the asking and answering of 3 questions and the use of Plan, Do, Study, Act cycles to test changes. The first question is, what are we trying to accomplish? And the answer to that gives us our aims for improvement. The second question we often ask in the model of improvement is, how will we know that a change is actually an improvement? And the answer to that is that we have to use and have relevant measures. The third question in our quality improvement arsenal is, what change can we make that will result in improvement? That answer is derived from cycles in which a plan is developed, carried out, studied, and then action occurs, and leading to further refined changes to get to the place that we would like to be. Next slide, please. In theory, and really the expectation, and I think a hope for many of us who work in this field, is that through repeated PDSA cycles, high quality patient experiences will result. Now, for that goal to be achieved, there are a few requirements. Next slide, please. The 4 requirements that you're seeing on this slide are really a summary from the literature, my own research, and speaking with executives and frontline staff through the years. The first requirement is good information. Having accurate and complete as possible information is critical for problem identification and root cause analysis. We need data that shows us where the pain points are. We also need data on what works, because we don't want to abandon those practices as we seek to improve other processes. We need information that doesn't just capture the experiences of some, but that helps us to understand the experiences for individuals with diverse backgrounds, so that we can be responsive to all and ensure high quality experiences for all. The second requirement for success is resources. Individuals in senior management and individuals at the front line of care will tell you how important resources are for improving care in many instances. Having time and technical resources like information sharing systems, human resources, able to perform tasks at the top of their ability. These are all precious resources for improvement efforts. The third requirement for success is workforce engagement, which exists when there's commitment and effort devoted to an endeavor. Plenty of research shows that workforce engagement is essential for overcoming powerful barriers to quality improvement that exist in complex settings like healthcare. When there's workforce engagement, we observe several attributes of workers that enable quality improvement efforts to be successful. We see a willingness to receive negative feedback, which is typically hard for people. No one likes to receive negative feedback, but hearing it and appreciating it is important for improvement. They engage, they see and value the opportunity to learn from less than optimal performance. When there's engagement, there's needed motivation to undertake improvement efforts, which is challenging. We see that there's willingness to trust others to use information for good and teamwork, true teamwork to actually improve. The fourth requirement for success is creative ideas for improvement. Creative ideas are those that are novel and useful by definition. Improvement is reliant on us having new ideas for how to perform current tasks better, and really ideas for new tasks as well. Next slide, please. Unfortunately, there are challenges associated with each of these requirements. We need information, but information is often missing. We need resources, but they're often limited. Workforce engagement is critical, but there's a natural human tendency to avoid negative feedback in difficult situations. And we struggle to identify creative ideas. And really, this is a twofold struggle. On one hand, there's the difficulty of generating new ideas when accustomed to the status quo. On the other hand, there's the difficulty of getting those who have creative ideas to share them. We know that there are dynamics in healthcare that keep many low-status individuals from voicing their concerns and suggestions. I offer these challenges to improvement that organizations generally face, with those in healthcare really not being exception from other industries. The struggles are the same across industries. I want to sort of make this personal for us, though, as we're talking about this subject today. And so I have a question for you. Next slide, please. And my question for all of you, and you'll see a poll pop up in a second, is which 2 challenges to improving patient experience perturb your organization the most? And so please answer this poll question using the link that is placed in the chat, or it should be popping up on our screens, I think, momentarily. And I'm asking you.
I'm sorry, Ingrid. We're having technical difficulties with the poll.
Oh, okay. Well, just keep going. So think in your own heads, what challenges are you experiencing? Now, next slide, please. So let's take the first challenge that I talked about, which is missing information. Research is showing us that narratives support information acquisition in at least 3 ways. And Rachel spoke to these, I think, quite clearly earlier, so I'm just going to repeat a little bit. They provide distinctive information, they provide actionable information, and we see equity in the voicing of ideas. The information that they give us is distinctive in that narrative comments provide greater insight on existing domains in closed-ended surveys. They're actionable because they give us insight that yields action items in many cases. And they offer equitable and diversity of information. We see in the data that the less empowered in society due to socioeconomical circumstances readily share their experiences through narratives. They are just as willing to tell their stories as those with more status if asked. Next slide, please. And some of you may be wondering, okay, so what are these questions that yield distinctive, actionable, and equitable information? The questions, which have been called at one point the narrative elicitation protocol, or now the narrative item set, were developed with the support of ARC, as Karen mentioned earlier, and they can be found on the ARC website. The questions essentially ask patients to share the most important things that they look for in a provider. They ask them, how do they think their provider and staff measured up, anything that's gone well, things they wish had gone differently, and how they relate to their provider. We see that these questions help to solve the information challenge. Next slide, please. We're also seeing in our research that narratives can be helpful for highlighting issues related to resources and therefore set the stage for improvements that allow for more efficient use of personnel and systems. There is a point that I have to make, though. Addressing issues raised in narratives can also increase resources needed. There's a cost to processing narrative data and potentially a cost to interventions that should come as a result of learning from those narrative data. Next slide, please. But we're seeing important benefits of narratives for addressing the third challenge, avoidance of negative feedback in difficult situations. My team has recently performed a study of the relationship between narrative use and healthcare staff's report of their own work experiences. In that work, our statistical analysis showed that the more healthcare workers receive frequent and useful comments from patients, the greater staff's job satisfaction and lower burnout. Our analyses further show that this relationship holds because patient comments are associated with confidence and understanding of patients and practice and patient-inspired behavior changes. These findings suggest that narratives can play a role in engaging workers for improvement. Workers appreciate and are responsive to the stories that they hear from patients in patients' own words. We're also seeing in some of our data analysis a connection to patient care experience scores as well. Next slide, please. Finally, we see evidence in our studies that narratives are a tool in combating challenge 4, the lack of creative ideas for improvement. We see in our research that patient narratives have creative ideas for improvement, and patients will share them if asked. We see that staff have creative ideas, that those ideas can be inspired by patient stories. And so while we may not think readily of narratives as part of the toolkit for improving patient experience, they most certainly are. We are seeing the ways in which narratives address several of the challenges that we have faced. They are providing missing information. They are allowing the opportunity for better use of resources. They're inspiring the workforce to be engaged in these efforts, and they're providing creative ideas for improvement that actually lead to improvement in patient care experiences. And so I want you to keep those ideas in mind, and I'm now going to open up the floor. I think we're going to open up the floor to have a discussion, and I'm looking forward to that. Thank you all for listening.
And Ingrid, let me add my thanks to you and to Rachel and to Karen for very rich and informative presentations about the power of patient narratives to tell us more about the patient experience and also to inform how the patient experience can be improved. So we are at that point in the webcast where we will pause and field questions from all of you. I do also want to just for the whole team apologize for some of the technical glitches along the way and our inability to use the poll. But let me begin with one of the first questions up, Ingrid. I think I'll toss it to you, a question by Andrew Golland, who was sort of asking to have a little bit more clarification about the definition of quality that you began with. Mm-hmm. He asks, is this a quality definition tailored toward a provider's perspective? Does it adequately capture patients' perceptions? Which is more important?
So that's a great question. So the definition that I showed you of quality is sort of a definition that's classically in the organization's literature. Now, you're raising an interesting question about whether patients, I showed you two definitions, right? So one is the classic definition from the organization's literature. And then the second definition is the one that we use. The National Academy of Medicine has given us this definition. Whether or not patients would actually say that this is exactly how they would characterize quality, it's hard for me to say that I know that answer. Do I think that they would they consider quality to be having desired outcomes that's consistent with professional knowledge? I think so. I think that those themes resonate from the National Academy of Sciences. I have not seen personally, I have not seen a definition that is a patient's definition that doesn't sort of include those two properties.
Great. Thank you, Ingrid. Rachel, you touched on the issue of equity in your remarks toward the end, and there are a number of questions posed during the registration process that also wanted to get at the issue of equity and diversity and the extent to which patient narratives can be used to capture experience, particularly on those issues. Would you like to sort of expand a little bit on how the narratives can inform our understanding of equity and diversity issues?
Certainly. So I think the first thing is to pick up on a point that Ingrid touched on, which is the desire of people across all kinds of ways that we may categorize them to tell their stories. And where we're sort of seeing that in our own work and data, the narrative item sets that AHRQ has invested in our team developing have been tested to make sure that they elicit stories that are complete, that are meaningful to those who listen, that are balanced in terms of what really happened in the degree of negativity and degree of positivity, and then most importantly from an equity lens, that are representative. That is, that the way we ask these questions, as Ingrid touched on, it matters how we asked, what the questions are, the ordering of them is inviting and successfully eliciting rich, meaningful, actionable narratives from people across demographic variables of all kinds. So that's been an important equity focus in the development of these narrative item sets. And then for those of you using CAP surveys in the network, you can certainly go back as you are looking at your own data and thinking about how to use it in your own settings and see, you can link back to the demographic data that's collected in the survey and see what kinds of different narratives may be emerging from different populations across race, across ethnicity, across age, across settings, and so forth.
Great. Thanks, Rachel. I just want to call your attention to the slide that's on the screen now that instructs you again how to answer or pose a question that you'd like to have answered. Ingrid, there's another question sort of getting at the issue of quality and its definition, and do the narratives shed more light on what leads to satisfaction and how does quality relate to satisfaction? This is posed by Pitsi Kawana.
Sure. So the work that we have been doing has been looking at the relationship between the frequency and usefulness of comments and healthcare workers' satisfaction. I think what I would say about that is that we're seeing two pathways by which that relationship appears to hold. And one pathway is that we're seeing that when workers, clinicians, and staff in practices are getting that narrative feedback, their confidence and their understanding of their patients and their practice tends to increase, and that is reassuring and therefore promoting of satisfaction and reducing burnout. The second pathway we see is that, so that's an informational pathway. That's a knowledge-based and sort of learning about your practice. The second pathway that we see fairly robustly in the data, and we're continuing to explore this association because we think it's actually quite important. The second pathway that we see is through behavior change. So individuals who report that they're seeing narratives, they're reading narratives, they're having access to them on a regular basis, they report that they're more likely, that they report that they've changed their behaviors. They report that they change their communications with patients. We see that they are more likely to have practice level changes, and that those are associated with people being more satisfied in the workplace and having burnout reductions. And I think this is important because it speaks to an association that we see sort of in the general management literature, that if you are attentive to healthcare workers, they're able to deliver better patient care experiences. And healthcare workers also want to know about patient care experiences. So there's a nice virtuous cycle that I think we're seeing happens in the data that we're studying.
Excellent. Thank you, Ingrid. Rachel, there's an interesting question from Bernice Adams, who is suggesting when she thinks of narratives, she imagines the written responses. So this is really about a question related to the collection of narratives and how that can be done in a way that is inclusive of patients with varying literacy levels or English as a second language. How can you just sort of describe how can narratives be collected in a way that respects these different sort of patient populations?
Yeah, thanks, Bernice. That's an excellent question. We have successfully translated some of these narrative item sets into Spanish and other languages. I think that is one key piece around reaching people for whom English is not a first language. We have tested our narrative item sets. Part of the sort of rigor baked into the development is to take a look at what we get when we ask these questions and people respond in writing versus fielding them on the telephone, and seeing what we get there. And certainly for some groups, the telephone responses can be a more appropriate tool. Of course, the way surveys are implemented will depend on the setting and on the resources, as Ingrid highlighted in her talk. But I would say that having some flexibility around modality as you implement your surveys and your settings will matter a great deal in terms of accessibility and reaching every voice. People are very willing to tell their stories, but you're entirely right. They need to be able to do so with an instrument that makes sense to them and for them.
Great. Thank you, Rachel. So Ingrid, I'm going to go back to another set of questions that were raised during the registration process that relate to once the information is collected from patients through a variety of mechanisms, what are some effective ways for providing that information back to clinicians and staff for their use and sort of getting at issues related to reporting and how this information can be most effectively shared for improvement?
Great. So I think that's such an important question. You know, it doesn't make any difference if you just collect the data and it's never shared with the people who can actually make change. And so one, make sure you share the information. Two, then you have to think about how to do that in a way that's effective for people to use it when we know everyone's working in a busy environment. Something that we've been doing experiment with New York Presbyterian for the last several years. And in that experiment, we have essentially been partnering with them. They have implemented a reporting interface that takes the coded narrative data and displays it in a way that is digestible to providers. And what's nice about this is that it aggregates so that providers, leaders, supervisors, anyone who has access to this reporting interface, digital, can see, even at a very high level, sort of positive to negative comments. They can see it linked to CAPS scores for the domains that both Karen and Rachel spoke about. You can see narratives that are specific to those domains, as well as narratives that are more distal and new and proximal. You can see the whole gamut. But you also have the ability in that template to scroll over and then read the patient's full narrative and get a better sense of what is happening in that context. A feature that we like about that reporting template is that those who use it have the option to sort of click on an action report. So they can even flag which narratives they want to use for their quality improvement efforts, whether that's to recognize something positive that's happening in the organization or to say, we need to work on this particular thing, and here's a narrative that's associated with it. So I think there's something to be said for when you have to share the information. Two, you have to think about how you're going to share the information in an effective way to do it. That experiment is allowing us to see whether that kind of digital reporting interface, how effective that is in making quality improvement around patient experience and narratives and CAP scores a little bit easier for those who want to do it.
Very good.
Can I just add, Dale,
Please.
apropos of this set of questions, which I agree are really critical, that not only does it matter that the information is getting back to people who can take action, but it also matters to getting rich data, to be communicating to the people we're asking to tell their stories, that they understand that they are taking the time to do something that will be fed back. And we have experimented with various kinds of sort of invitation language preceding the narrative item set, and really come to understand that patients and families who are filling out CAP surveys, and getting to the narrative items, that they want to know that this will be used to help make care better for other people. I think there is a real impulse to participate in telling your story to make things better for others. So it matters sort of on both sides, getting the richer data as well as making sure the rich data that we're getting is put to use.
Rachel, just to kind of continue on the issue of ways in which the data can be collected, this question was posed earlier on registration regarding ways beyond using the narrative item sets in conjunction with a CAP survey, but to use those items in other ways. And I'm thinking about, for example, some of the research I know that you've done with NYP, learning about other ways in which clinicians and staff actually gain information directly from patients. And how does that sort of fit in with this overarching sort of idea of getting patient feedback in their own words?
Yeah, I mean, I think there are many modalities that we've been hearing in open-ended responses from people who work in the NYP ambulatory care network about the value of feedback that's in writing and can be thought about, that includes sort of written down creative ideas that can be presented to others who may have a lot of ability to free up resources or sort of advocate for resources within an organizational setting. So lots of power in the written narratives, and also lots of ability to sort of fine tune that listening and go out and get data from people live. We've been hearing in the network how valuable it can be if people do include their contact information, if their survey instrument includes a place to optionally say, here's me and you can contact me back, that there's a lot of value in being able to directly close that feedback loop directly with a patient who took the time to give that rich feedback, and that's something that people in clinical settings highly value, that sort of dialogue that can come.
Mm-hmm. Thank you. So Ingrid, you've mentioned the New York Presbyterian work that you've been doing. Are there examples, one maybe or two, that you can give that sort of address how this information has actually been used for improvement or could potentially be inserted into a QI process?
Sure. So that part we've, in all honesty, done a little bit less with, but hope to pursue. I think the things that you can, in some sense, once you have an idea, you are, whether it's from a narrative or another source, you're in that quality improvement process that I spoke about earlier, right? So one could imagine that you are, as an organization, so speaking practice-wise now, you can do a PDSA cycle to implement those ideas. You can imagine some organizations might rely on, take those ideas and take them to a PFAC and say, okay, we have 20 ideas that have come in this month. What do you think about this? You know our organization, you know our structure. Those ideas can be taken to staff meetings and can be discussed in staff meetings. Staff can weigh in on those ideas and those. And so I think at that point, the process becomes similar to quality improvement. But the potential advantage that we see with narratives is that you're getting these ideas, a fresh source of ideas that are coming from, that are actually rooted in experience and have the potential to change experience. And so they're providing another source of information. And I think that is the leverage. The process might actually look quite similar. I would just add on to something that Rachel said, and I've heard her say has been coming out of some of the interviews that she's been doing, and has surfaced in conversations I've had as well, is sort of closing the loop on improvement, which Rachel was starting to speak about, and I think closing it for patients as well, that patients also want to know that once they've written, you know, telling that, oh, this idea, once it gets implemented, this idea was brought by an idea submitted by a patient. You know, some of that I don't think we know as much about, but I think I've heard Rachel say that that is something that has been bubbling up in some of the conversations that she has been having.
Right.
Very true. And I think I can just add to what you described so well just now, Ingrid, that we've heard some concrete ideas that have already led to improvement projects from the narratives in the NYP ambulatory care network, such as changing the practice of seeing patients who arrive late for their appointments, such that those patients are offered to be seen at the end of the clinic session, so they're not turned away, but it doesn't create problems of waiting for every other person with an appointment in that session, because they're trying to squeeze them in close to their appointment time, and they've seen how there can be this cascade of comments, like every single person that day saying, I had to wait an inordinately long time for my appointment. We've heard improvement ideas related to privacy when people are being weighed, and where those scales are and who can hear what somebody's weight is, and how to rearrange, using clinic redesign principles so that privacy and clinical processes can both be valued together. We've heard about the establishment of sort of rounding in waiting rooms, so that people are, even if they are waiting or if there are issues, they're being kept informed. And these kinds of things tie back to positive feedback, negative feedback, and creative ideas that have come from patients. Those are just a few examples that we're hearing in these interviews.
Well, those examples are really helpful. We are coming up very close to the hour, and I just want to think we have time for one more question. Rachel, I think this is for you, because it has to do with the how much extra burden or opportunity is there in actually providing answers to these narrative items, and has it depressed response rates at all to CAP surveys or to the actual completion of the questions when they're posed?
I have no knowledge of it depressing response rates. We often describe the narrative item set as a 5-question, 5-minute protocol. That's about the average that it takes people to answer it. And we see very, very little, if any, statistically significant fall off in the answering of questions. They are, again, designed to elicit a story, to go in sequence. And we have experimented in designing these with different orders and different questions, and really alighted on the one that we hope for most respondents sort of feels like, oh, I'm glad you're asking me this, because that's the next thing that the question before made me start to think about.
Right. I would just quickly add too that we've seen some evidence that the promise of being able to answer open-ended questions at the end of a survey actually sort of may have a positive influence on response rates overall, and that we see no decline in from moving from the closing questions to the answering the narrative questions. It's pretty much a seamless step from one to the other. Well, this has been terrific. I want to thank you again, Rachel and Ingrid and Karen, for all of your wonderful presentations and your comments and your answers to these questions. And also to all of you who participated in our webcast today. We do send out periodically updates that relate to new upcoming webcasts or submission deadlines for the CAPS databases or other products. You can sign up to get an email alert by going to our website shown here. There's a little icon up in the upper right-hand corner that you select, and then you can indicate that you want to receive periodic updates regarding the CAPS program. Next slide. So we're always available to answer questions either by email at caps1@westat.com or by phone at the 1-800 number, 1-800-492-9261, and a website that we maintain, which is a rich source of information and resources about all kinds of issues related to CAPS surveys, including patient narratives. And that is at www.ahrq.gov/CAHPS. And finally, when you do leave the webcast today, you're going to be given an opportunity to do a very short survey, which we ask you to sort of complete because your feedback is important to help us know how we can improve these offerings in the future. So thanks again for your participation and have a great rest of your week.